Assalamualaikum warahmatullahi ta'ala wabarakatuh. Greetings of peace. Good morning to each and everyone. So for today's video, we will continue our discussion for the review of systems. So previously, we have discussed the three systems. So integumentary system, the HENT, and your respiratory system. So now let's continue our discussion for this module 4, the review of systems, particularly on cardiovascular system, your gastrointestinal system or your digestive system, and your musculoskeletal system. So let's start first with your assessing the cardiovascular system, particularly the heart, the blood vessels. Okay, now, so let's have a quick review of your conductions. As you can see here in this image, this is the electrical system of the heart, meaning this is where the electrical signals is sent to for the heart to pump regularly every now and then. So we have here the different nodes. We have the SA node, we have your atrioventricular node, your right bundle branch, your conductive pathways, which is in the left bundle branch, and your Bachmann bundle. So this is where, okay, the electrical signals is sent for the heart to pump every single time for the heart to receive the oxygenated blood from throughout the body and to release oxygenated blood all throughout the body. So we have here the cardiac cycle, the arterial systole. So by the time that the atrium contracts, what happens? When the atrium contracts, it receives the deoxygenated blood all throughout the body, particularly in the right atrium. So right atrium is the one that receives the deoxygenated blood from the other parts of the body. After the atria, and while your left atrium receives the oxygenated blood from the lungs. So after the atrial systole, we will have, after that, we have your ventricular systole or the contractions of ventricles. Now, what happens during the ventricular systole? At the right ventricle, during the contraction of the ventricle, of the right ventricle, it gives the oxygenated blood papunta or through to the lungs, okay? And then after that, on the left ventricle, remember, diba, the left atrium received the oxygenated blood from the lungs. So that oxygenated blood, they will go through the right ventricle, and this left ventricle will pass it to the aorta so that it will be given to other parts of the body. So then after, we have your diastole, wherein your atrium and your ventriculars relaxes. Okay, and it will go round as a cycle. Okay, so this is a repetitive this is a repetitive action of your heart in order for us to provide a good blood circulation all throughout the body. Now, the peripheral vascular system, so actually, again, it is named, so the cardiovascular system is named based on the anatomical features of the system. So cardio means the heart and the vascular means the blood vessels. Now, if we were to talk about their function, it is named as circulatory system. Why? Because they are the one responsible for blood circulation. So your peripheral vascular system composed of 3 blood vessels. So we do have 3 types of blood vessels. Again, we have your veins, we have your arteries, and we have your capillaries. And each one of them have different processes or functions. So your arteries carries blood away from the heart. They carry oxygen-rich blood from the heart throughout the rest of the body. However, we do have a specific artery that carries unoxygenated blood, particularly your pulmonary artery, because this artery receives the unoxygenated blood from the right ventricles and it sends it to the lungs for oxygenation. Now we have your capillaries. This is the very tiny blood vessels that is responsible for exchange of fluid, nutrients, and metabolic wastes between the cells and blood. Now the last is your veins. Veins carries blood towards the heart and they usually carry oxygen depleted blood. However, there is a particular vein that carries oxygenated blood, which is your pulmonary vein. This pulmonary vein receives the oxygenated blood from the lungs and then they will give it to the left atrium. Okay. So now let's proceed. What are the things that we need to assess, particularly in your cardiovascular system? So we have here, first is to assess general appearance. Why do we need to assess general appearance? Because at some point, those patients who experience cardiovascular problem, it is actually seen particularly in their general appearance. So what are the things that we need to check? First is your weight. So patient who experience rapid weight gain, okay, without any reason, so maybe it is due to edema. And edema can be a sign of heart problem. That's why you have to check the weight. The next one is the level of consciousness. If the patient is unconscious, stupor, alert, so maybe there is not good enough oxygen traveling to their brain. That's why the patient experiences disorientations or alterations in their level of consciousness. That's why you have to check on that. And then we have the skin color. Remember that the blood circulating in the body gives us the color pink. Okay, pinkish, our mucosas are pink because of the blood circulation. Now, if you experience pallor or cyanosis, that would mean a lot. That would mean there is a problem with the oxygen traveling throughout your body. Another is your skin temperature. So the reason why we are warm-blooded people, because of blood. Okay? So without blood, you will experience hypothermia or or a decrease in body temperature. The next, we have your skin turgor. Then we have your skin texture. And last but not the least is the clubbing of fingers. So yung your hands is the nails, the hands is more likely it will tell that there is a poor blood circulation. Okay, so what are the things that we need to inspect other than the general observation? So first, we have your inspection. So in assessing the neck vessels, particularly our jugular vein, okay, or carotid artery, inspect the vessels in the patient's neck. Carotid artery should appear to have a brisk and localized pulsation, and it normally protrudes when patient is lying down and lies flat when he stands. Okay. Now, for your palpation, after inspecting, you have to use a good light for you to see that, And then for palpation, to palpate the carotid artery, lightly place your fingers just medial to the trachea and below the angle of jaw. Remember, when you palpate the carotid artery of your patient, do not palpate on the both sides. You have to palpate one side at a time because it can occlude the blood circulation to the brain. Then the pulse should be regular in rhythm and have equal strength in the right and left carotid arteries, and no palpable vibrations or thrills must be noted. Now, in assessing the neck in auscultation, so after you inspect, you palpate, we do not percuss, okay? We do not percuss when it comes to assessing the neck vessels. We then auscultate. So what do we need to auscultate? You auscultate for the pulse. You have to take note the pulse rate, the rhythm of the carotid pulse. So ask the patient to hold his breath and no vascular sound must be noted. And brewy sound means abnormal findings. So in evaluating your jugular vein distension, you have to ask the patient to place themselves in a supine position with 45 to 90 degrees head of bed. So elevated head of bed. And then locate the angle of Louis, usually in the sternal notch. So it should be greater than 30, if the greater than 3 to 4 centimeter above the sternal notch indicates jugular vein distension. So if it's about greater than 3 to 4 centimeter above the sternal notch, it indicates jugular distension. So normally it should be in 1 to 2 centimeter. So assessing the heart. So how do we assess the heart? So you have to inspect the chest and note the cardiovascular landmarks. So these are the landmarks. So we have here the suprasternal notch. We have your aortic area. We have your pulmonic area. We have your tricuspid area. And we have your mitral area. So this is the specific areas that you need to take note, especially because this is the correct areas wherein you will auscultate for any vascular sounds and heart sounds. So again, we have your sternoclavicular area, we have your aortic area, we have your mitral area, and we have your tricuspid area. So inspect the chest and note cardiovascular landmarks. Look for any pulsations, symmetry of movement, retractions, or heaves. Note also the location of the apical pulse, which is usually on the 5th intercostal space or mid-clavicular line. So our apical pulse is good as what we call your heart rate. We do have difference when it comes to terminologies, the pulse rate and the heart rate. Heart rate represents your apical pulse. Because why is it called the heart rate? Because it is closer to the heart, because it is the apex of the heart. So that specifically means that it is the rate of the heart during in 1 full minute pumping. Okay, now for your pulse rate, this is actually for the peripheral pulses, including your carotid pulse, your brachial pulse, your your radial pulse, popliteal, dorsalis pedis. So we have different peripheral pulses in our body. So palpation, follow a systematic palpation sequence. You start with your sternoclavicular, then aortic, then your pulmonic, then your tricuspid, and then the epigastric areas for any pulsations. So for percussion, you percuss the anterior axillary line, sternum along the 5th intercostal space. So you percuss for any signs of resonance, dullness, hyperresonance, or any abnormalities. So for auscultation, position the patient either lying on supine, lateral, or sitting position. Use a zigzag pattern over the precordium. Note for the heart rate and rhythm, and identify your S1, your S2, your S3, and S4. Sa heart sound, these are what we call your heart sounds. So your S1 and S2 are the normal sounds, while your S3 and S4 are your abnormal sounds. So you have to take note of that. So this is the zigzag pattern. You may start with aortic and then go to pulmonic, and then go to Erb's point, and then go to tricuspid, and then mitral area. So you can use this zigzag pattern during your auscultation. Now, let's go to your assessing the vascular system. So inspect for the equal arm size, this is the symmetrical legs, and check for the skin color, the body hair distributions, the lesions, the scars, the clubbing, and any presence of edema of extremities. Okay, so usually edema is related to a right-sided heart failure. Left-sided heart failure, because remember, our left side of the heart is responsible for the systemic circulation, while your right-sided heart failure is responsible while your right side of the heart is responsible for the pulmonary or pulmonic circulation. Now for your palpation, palpate for the skin temperature, again using the back of your or dorsal part of your hands. You check for the skin temperature, for the surface temperature, and then the texture and the turgor. Assess for capillary refill of the nail bed. So normally it is less than 2 to 3 seconds. Palpate the arms and legs for any edema. So we have 2 types of edema, non-pitting or pitting. Pitting meaning it has indentation or it leaves marks after pinching or placing the finger on the part, and then non-pitting, there is no a indentation. So palpate peripheral pulses. Again, these are the one that I have mentioned earlier. We have your temporal pulse, we have your carotid pulse, we have your brachial pulse, we have your radial pulse, we have your femoral pulse, popliteal pulse, posterior tibial, and dorsalis pedis. So you check for the or to grade the pulse. So we have here the grading of pulses. So if it is bounding pulse, so 4 positive. If it's increased, it is 3 positive. If it's normal, 2 positive. And if it's weak, 1 positive. So you have to take note the pulse strength of this peripheral pulses. So you're not just assessing it on one side of the body. It should be compared to the other side of the body. And 0 if it's absent. Now for your auscultation, always remember to use the bell of your stethoscope following the palpation sequence earlier. So you auscultate for the vascular sounds and assess for any abdominal aneurysm or Brewy sound. Okay, so again, normal findings that we can find in assessing your cardiovascular system. So for the skin color, if it's pallor or cyanosis, meaning that's a problem in the it may suggest that there is a problem in the cardiovascular system of your patient. For the edema, again, it may be non-pitting or pitting. So pitting causes an indentation that slowly fills, and non-pitting, it causes or leaves no indentation, and the skin usually feels tight. And then for abnormal pulsations, if it's displaced apical pulse, it may suggest heart failure or hypertension. Forced apical pulse, it may suggest an increased cardiac output. Aortic, pulmonic, or tricuspid pulsation, it may suggest heart enlargement. If there's an epigastric pulsation, it may suggest heart failure or aortic aneurysm. Sternoclavicular pulsation, it may suggest aortic aneurysm. Slight left and right sternal pulsation, it may suggest anemia or anxiety. And sternal border heave may suggest ventricular aneurysm. So you have to check this one. And if it's if it's what they call assessed in a patient, then it may suggest different heart problems or cardiovascular problems. Okay, so now let's proceed to the next system. You're assessing the gastrointestinal system. Again, let's review on your assessing the cardiovascular system. We particularly use the 4 methods. We inspect, we palpate, we percuss, and we auscultate. However, on pulses or vascular system, we do not use percussion. We don't percuss the different pulsations because there is no sounds to be elicit. Okay, so now let's proceed to your assessing your gastrointestinal system or your digestive system. So now let's start with what are the things that we need to interview or assess from the patient based on their subjective data. So for general, during your health history, you may ask the patient for any presence of dental prosthesis, and then the comfort of usage, difficulty of eating or digesting food if they experience that one. If they have recently experienced unexplained weight loss, okay, you have to take note of that one. And if they have experienced pain from any parts of their abdominal region. Now, pain may be caused by distension or sudden contraction of any part of the GIT or gastrointestinal tract. So you assess for any rebound tenderness. Okay, so wherein you palpate the affected area, and the moment you release your hand, the patient will feel pain. That is what we call rebound tenderness. Assess for the iliopsoas sign, wherein you ask the patient to raise their leg, and if it's painful on the abdominal cavity, that is your positive iliopsoas sign. Then assess also for obturator sign, where you ask the patient in a supine position, you flex their leg, and if there is a pain in the abdominal cavity, that is a positive obturator sign. So here is the common site of referred for abdominal pain. Okay, so we have here, if it aches here at the side of your shoulder, liver problem. Here at the breast area, chest area, we have your heart, we have your biliary colic. Okay, we have your cholecystitis, pancreatitis. So you have to, you may refer to this picture so that you have an idea what do you call to your common site of referred abdominal pain. So when we talk about referred pain, this is the type of pain where the patient can feel the pain not on the affected area. That's why it is referred. The pain is on the site wherein the problem is not the location of the problem. Okay? So it's just a reference or referred. So assess also for any specific data if there is a present symptoms of the patient. So situations or events that affects the symptoms, you ask the onset, the possible cause, the location, the duration, the character of symptoms. Because we have different quadrants in our abdomen, we have different regions in our abdomen, and each region have specific or particular organs where we can assess that one. So relationship of specific foods, smoking, alcohol to severity of the symptoms. Because particularly in relation to food, there are diseases that is related or has a relationship with food. Example, we have your gastric ulcer and peptic ulcer. One type of ulcer is caused by the pain is caused by ingesting food, and the other one, once the patient is not able to ingest food, the pain is not there. Okay, so check also how the patient how the symptoms was managed before seeking medical help. So you may also check for the normal pattern of bowel elimination. Normally we eliminate at least once a day, and then maximum of twice a day with the semi-solid stool. Okay, so if it's alternate or every other day, then you don't have a good bowel elimination. So you have to take note of your diet and increase fiber in your diet, and also ask for the or for the use of any laxatives or enemas if ever the patient can experience difficulty of eliminating or difficulty of defecating, then they use this type of medications or treatments, then you have to take note of that. So assess also for any recent changes in the normal patterns, if there is a changes in the characteristics of the stool. Okay, so later on we will learn what are the different characteristics of the stool using the Bristol stool chart. And then we have your changes in the color of the stool, because melena, we have here two particular changes in the color of the stool. Melena, it is the black starry stool, which may signify that there is an upper gastric or gastrointestinal bleeding. And then for your hematochezia, a fresh blood in the stool, which may signal us that the patient may experience a lower GI bleeding. So you also ask for any medications or drugs that they take, because example for iron, if the patient is taking iron, they may experience black stool. And then measures taken to relieve symptoms. So we have here again earlier I mentioned the stool characteristics. So we have here the Bristol stool chart. Then you can ask the patient to describe their stool by using and check it by using and compare it, by using this chart. So you can see here, the normal are type 3 and type 4. Type 5 and 6, 7 is usually due to lack of fiber or any inflammations around the GI gut. And then for your type 1 and type 2, it may signals means that the patient is experiencing constipation. So to avoid constipation, you increase fluid intake, you have to increase fiber, you have to decrease fat intake, because this is the common reason why do we feel constipated, because of ingesting too much fat and less water. So this chart, you can use this one, okay, to check and compare and ask the patient what type of stool do they eliminate. Okay, so next you check for the objective data. So in physical assessment actually of your abdomen, we use the technique of AA-PEPA. What is AA-PEPA? Inspection, and then you auscultate, and then you percuss and you palpate. Why do we need to auscultate first before we percuss and palpate? Because we do not want to change the bowel sounds. That's why, to avoid alterations of the bowel sound, we auscultate first before we percuss and palpate. Because percussion and palpation can alterate the bowel sound. So for abdomen, you assess for the presence or absence of tenderness, any organ enlargement, any masses, any spasms or rigidity of the abdominal muscles, any fluid or air in the abdominal cavity. So these are the just anatomic locations of the organs, particularly in the 4 quadrants of our abdomen. So, right upper quadrant, this includes your liver, the gallbladder, duodenum, right kidney, and the hepatic flexure of the colon. For the right lower quadrant, we have your cecum, your appendix, your right ovary, and right fallopian tube. For the left upper quadrant, we have your stomach, we have your spleen, we have your left kidney, we have your pancreas, and we have your splenic flexure of your colon. And for the left lower quadrant, we have your sigmoid colon, left ovary, and left fallopian tube. So you have to take note of this anatomic locations of the organs. So if the patient particularly experiencing pain in that area, so take note that this area of pain should be assessed last, okay ha? And especially in abdominal cavity. Any location of wherein the pain is felt, you have to assess it last. Because the moment you assess it first, the pain may radiate from one quadrant to another quadrant. So you have to assess the pain area last. So again, here are your quadrants, and here are your regions. So we have actually 9 regions, namely your right hypochondriac, epigastric, and left hypochondriac. We have your right and left lumbar region and your umbilical region. We have your right and left iliac region and your hypogastric region. So again, the assessment technique, first is inspection. So what are the things that you need to inspect? Assess the skin and the abdomen for color, texture, scars, striae, or stretch marks. We have your engorged veins, visible peristalsis. If there is a visible peristalsis, then it may suggest intestinal obstruction. Visible pulsations, it may suggest abdominal aorta. And visible masses, it may suggest hernia. Assess the contour if it's flat, protuberant, or globular. Assess if the umbilicus, if it's in midline or not. Assess also for any abdominal distension. Measure the abdominal girth or circumference at the level of umbilicus or 2 to 5 centimeter below. So, auscultate. What are the things that we need to auscultate? Siyempre, your bowel sounds. Okay? So, auscultate in a clockwise fashion in each quadrants. Note presence or absence of your peristalsis or bowel sound. So, we have here different types of bowel sounds. We have your normoactive, where you can auscultate at least one sound every 5 to 20 seconds. Hypoactive, you can auscultate 1 or 2 sounds in 2 minutes. Absent, if there is no sounds in 3 to 5 minutes, maximum of 5 minutes you have to listen. Okay, so it may suggest peritonitis or paralytic ileus. And then for hyperactive bowel sound, you may auscultate at least 5 to 6 sounds in less than 30 seconds. So it may suggest diarrhea, gastroenteritis, or early intestinal obstruction. Okay, so auscultate for the auscultate also for the abdomen for the vascular sounds. Okay, so here are your vascular sounds in the abdomen area. We have your hepatic friction rub, the splenic friction rub, your aorta, your renal artery, your venous hum. We have your iliac artery, and we have your femoral artery. So I suggest you watch videos in the YouTube or any videos that could really give you an idea what's the sound of this specific vascular sound. So kasi I cannot describe it properly. So after auscultation, we have to percuss. So you may use indirect or direct percussion. So why do we need to percuss the abdomen of the patient? It is done to confirm the size of any various organs. It's also used to determine any presence of excessive amounts of air or fluid in the abdomen. So normally, and specifically in your stomach area, normally it is tympani. While in your areas of liver, spleen, or solid structure, you may palpate, percuss dullness and flatness. However, again, warning, do not percuss if the patient has an abdominal aortic aneurysm. Why? Because the aneurysm may, ano to? Puputok. What do you call this? May cause it may aggravate the problem. Okay, so next we have your palpation. So after you inspect, you auscultate, percuss, lastly you palpate. So you palpate the abdomen. You may use light and deep palpation to determine the size of the liver, the spleen, the uterus or kidneys if it's enlarged, and determine the presence or any characteristics of any abdominal masses, and to determine the degree of tenderness and muscle rigidity, if there is a rebound tenderness or direct tenderness. So, for the rectum, okay, what are the things that you need to check for the rectum? Check for or inspect the perineal and perianal skin. Assess for any presence of pruritus or pangangati or itchiness, okay? Any fissures, any external hemorrhoids or rectal prolapse. So, in assessing the rectum or anus of the patient, place the patient in a left lateral or Sims position. For prostate exam for male patients, have them bend over forward with hips flexed and upper body resting on the table and bed. So drape the patient properly to avoid unnecessary exposure of your genitalia. So do not forget to use gloved hands, okay? So that's all for your gastrointestinal system. So again in cardiovascular system, we use the 4 methods in this order: inspection, palpation, percussion, and auscultation. Except for your vascular system, we do not percuss our pulse sites. Now, for your assessing the gastrointestinal system, you use the technique inspection, auscultation, percussion, and palpation. Now, for your assessing the musculoskeletal system, we use the inspection, we palpate, we percuss, and we percuss only. We don't use auscultation in assessing your musculoskeletal system. So, for the general data, okay, for the musculoskeletal system, take note of the size, the shape of joints, the limbs, and the body regions. Okay, you note the patient standing positions or any movement. Okay, you take note of that, and you ask the patient or let the patient walk across the room and assess the bones and joints through your range of motion. So what are the types of range of motions that you can ask the patient to perform in order for you to assess their movement? So we have your retraction, your protraction, your flexion, extension, circumduction, abduction, adduction, internal and external rotation, your pronation, supination, eversion, and inversion. So these are just typical range of motion that you can ask the patient to perform in order for you to assess their movement, their ability to move their joints throughout different motions. So, evaluate the temporomandibular joint. Inspect for any swelling. So, starting from the head. So, assessing the musculoskeletal system, you start with the head down to your toes. So, assess for or inspect for any swelling, symmetry, and trauma. Evaluate the range of motion of the mandibular joint by asking the patient to close and open his mouth. Assess the patient's neck and neck range of motion. Inspect for tenderness. Inspect for swelling or nodules. Check range of motion in the neck by asking them to move their neck to move their ear to shoulder. Let their ear touches their shoulder, and then their chin touches their chest, and then their chin looking up or in ceiling rotation, and then you rotate. Then assess for the spinal position and curvature and the range of motion by asking the patient to lean forward and with the sitting position to check for the spinal curvature. Note for any tenderness, swelling, or spasm of the spine through palpation, and ask the patient to bend forward at the waist, then measure the length of the spine. So note for any abnormal deviation of the spine, such as your scoliosis, the kyphosis, the kyphoscoliosis, or lordosis. If you can still remember the one that I have discussed in respiratory system, in chest area, so you have to take note of that. Okay. And then assess for the shoulder and then elbow. Note for any asymmetry, muscle atrophy, or deformity. Note for any crepitus or any tenderness in the muscles. Note for shoulder muscle for firmness and symmetry. Palpate the elbow and ulna for subcutaneous nodules. And assess for shoulder range of motion, such as you can ask them to perform abduction, adduction, forward motion, backward extension, flexion, extension, external and internal rotation, supination, and pronation. So for the wrist and hands and fingers, you note for any tenderness, nodules, or bogginess, and assess for range of motion. The same, radial ulnar deviation, extension, flexion of the fingers, the wrist, and abduction and adduction of your fingers. So you may also assess for signs of carpal tunnel syndrome. Okay, we have your Tinel signs and Fallon signs. If there is a pain around the wrist area of the patient while flexing and extending the wrist, that's a positive sign that the patient may experience carpal tunnel syndrome. Okay. So for your hips and knees, assess for the hip range of motion, the flexion and extension, the internal and external rotation, and your abduction and adduction. For your knee range of motion, standing position, flexion, assess for bulge sign, wherein you ask the patient to lie down and palpate the knee for any pain. And then assess for the ankles and feet. Expect for the swelling, redness, and nodules and other deformities. Note for any calluses, bunions, corns, ingrown toenails, plantar warts, ulcers, hair loss, or any unusual pigmentation. You may also assess for range of motion such as hyperextension, plantar reflection, eversion, inversion. Assess for shoulder, arm, and wrist, and for hand strength. Okay, ask the patient to extend their arms with palms up for 30 seconds. Assess for bicep strength, the tricep strength, the quadricep strength, and ankle strength. So, I forgot to mention this one. In assessing the musculoskeletal system, there are three things that you need to take note, no? The muscle mass, which is the weight of the patient and measurement of their muscle circumference. The muscle strength, wherein you grade the strength of the patient's ability to resist resistance, and their muscle movement or their range of motion. So these are the three things that you need to take note when assessing the musculoskeletal system. So grading for muscle strength, we have here the grading. So 5/5 is normal, wherein the patient is able to move joint through the full range of motion and against gravity with full resistance. 4/5 is good if the patient completes range of motion against gravity and with moderate resistance. Now for fair, the patient completes range of motion, however, against gravity only. If it's against resistance, the patient cannot move. Then 2/5 is poor. The patient's complete full range of motion with gravity eliminated. So you have to assist the patient to flex and extend. However, with gravity, they cannot move at their own. And then 1/5 is trace. The patients can attempt to move at muscle contraction. However, the muscle contraction is palpable, but there is no joint movement. And 0 is no evidence of any muscle contraction. So common musculoskeletal for abnormalities that may be seen and checked in patients. So we have your foot drop, where there is a plantar flexion of the foot with toes bent toward the instep. We have your muscle spasms, a painful contraction of muscles. We have your muscle atrophy. When we say muscle atrophy, the it results to a prolonged use of muscle disuse. That's why the muscles cannot contract now, or there is no movement. So, crepitus is abnormal crunching or grating of the joint, maybe due to lack of synovial fluid in the joints. And this is very common when in older age or older adults. So muscle weakness results from maybe result from a malfunction in the nervous system, because take note that your brain, usually your nervous system, what do you call this, controls your movement, because it is more on based on voluntary control. Now, traumatic injury may result from any fractures, any dislocations, any amputations, or crush injuries and lacerations. Now, pain is anywhere from where to from anywhere from hand to shoulder or legs. You have to check that one. So remember the pain assessment, PQRST. I think I know. I hope you're familiar with this one, the PQRST pain assessment, wherein you ask the patient what provokes their pain, what's the quality of the pain, where is the region of the pain, or where does it radiates, the what they call this, severity of the pain, basing on the pain score and the time and duration of the pain. That is the PQRST pain assessment. P, provoke. Q, quality. R, the region or radiation. S, severity. And T, time or duration. Okay, so I think that ends my discussion for today. I hope you have you don't have any clarifications or questions about my topics. Again, if you do so, please do not hesitate to comment down below what's your question, so that I can answer your questions regarding my topic. So once again, thank you for watching my module. I'm very sorry for the background noise, because it's raining heavily here in the Philippines, and I'm really sorry for that. So again, if you cannot really hear my voice in this video discussion, do not hesitate to ask me, and I can also give you a copy of my presentation, so that you can follow my discussion. You can follow during my discussion. So thank you again, and wassalam.